like to invite up Riley O'Meara, who will be presenting on amputation recovery in the unhoused population on behalf of the Loyola Group.
Thank you for the opportunity to present this project on lower extremity amputation in the unhoused population. I have nothing to disclose. Despite advancing options in revascularization strategies, lower extremity amputation remains an essential component of vascular surgery practice, with 185,000 major amputations occurring annually and 2 million individuals living with limb loss in the United States. A recent VQI study demonstrated that race and low socioeconomic status have independent associations with poor functional recovery following major lower extremity amputation. Unhoused patients are a group at high risk for amputation, largely due to higher rates of cardiovascular disease prevalence, higher rates of foot infection treatment failure, and poorer diabetes control. In 2024, there were over 770,000 people identified as experiencing homelessness in the United States. This was an 18% increase in this population from the last year. In the city of Chicago alone, there were just under 19,000 homeless individuals and a 65% increase in the amount of unsheltered homeless individuals from last year. So homelessness both creates new health problems and exacerbates existing ones, and we can expect to see more of these patients in the future as this population is increasing. Housing status itself is a variable that's not often captured in large databases, but it is a demographic characteristic that has profound impacts on patient health. For example, the VQI utilizes Area of Deprivation Index as a placeholder for socioeconomic status, but this is something that's based on patient zip code and relies upon patients having a physical address on file, which often overlooks unhoused patients. Amputation is something that the unhoused are at high risk for, but as far as we're aware, it's not something that's been formally studied in this group, which was our intention with this study. This was a single institution retrospective analysis of 1,300 patients who underwent major lower extremity amputation between 2007 and 2021. Our inclusion was limited to below, through, and above knee amputations that were performed by a vascular surgeon. Patients were separated into a housed cohort and an unhoused cohort using ICD-10 codes related to homelessness and confirmed with manual chart review of social worker and physical therapist notes that documented housing status during the patient's admission for their amputation. Table 1 contains our patient demographics, which showed a significant difference in age at the time of amputation, with the unhoused cohort being on average 9 years younger than the housed cohort. Type of insurance was also significantly different between the groups, with the unhoused cohort having a higher rate of Medicaid and the housed cohort having a higher rate of Medicare insurance. Table 2 contains preoperative comorbidities, which showed a significant difference between smoking status, with the unhoused group having higher rates of current smokers. There was a significant difference in rates of CKD, diabetes, hypertension, and PAD, with the unhoused group having lower rates of diagnosis of these conditions. The unhoused cohort was also significantly less likely to be taking an antiplatelet or a statin medication prior to their amputation. They were also less likely to have received a lower extremity angiogram prior to their amputation. In terms of postoperative complications, the unhoused cohort showed a significantly higher rate of surgical site infections within 30 days of their amputation. This table shows our recovery outcomes of interest. On average, the unhoused cohort spent a longer amount of time in the hospital, with an average total length of stay of 19 days compared to 11 days in the housed group, and an average time from surgery to discharge of 12 days compared to 6 days. There was not a significant difference in discharge location between groups, with similar utilization of rehab facilities. Both groups had similar rates of ambulation following their amputation, but the amount of time that it took to become ambulatory was significantly different, with the unhoused group achieving ambulatory status on average a day later than their housed counterparts. The unhoused group was also significantly less likely to have any sort of follow-up with their vascular surgeon within a year of their amputation. It's well known that more socioeconomically disadvantaged patients tend to present with more advanced disease and have worse surgical outcomes. So the question becomes, what are ways that we can intervene earlier to try to improve outcomes for these patients? Something we've done at Loyola to directly tackle this access to care issue for a very specific patient population was the creation of our Loyola Street Medicine group. Street medicine has the goal of eliminating barriers to care by bringing medical equipment and providers directly to places where unsheltered homeless people congregate in order to meet people where they are. One of our most successful forms of outreach has been through our partnership with the Chicago Transit Authority. Every week we construct a clinic in the train station at the end of the Blue Line where we are able to see a variety of patients and provide a variety of preventative care. This is something that both can help optimize a lot of the comorbid conditions that patients present with that require medical management, also provides an opportunity for consistent wound care and an opportunity for earlier contact with a medical provider and referral to specialists as needed. We also started an inpatient consult service. This is something that we think is especially effective for patients post-operatively in the hospital. We're able to refer them directly to our clinic as a means of follow-up if they are unlikely to see a physician after their amputation. This outreach strategy is something that has been really effective for this population. So at the clinic, we utilize an electronic health record, and we chart every encounter with our patients just like we would in an outpatient setting. Over the past 3 years, we've had 2,094 medical encounters with unhoused patients, and these numbers have been increasing every year. Most of the patients that we see are chronically homeless, with 64% of them having been unhoused for longer than 6 months at the time that we see them. In addition, most of the patients that we see do have some form of insurance, with only 21% of them being uninsured. We see a wide variety of chief complaints at this clinic, but the two most common issues that people present with are wound care or podiatry related. This represents about a third of all of the medical encounters that we see and shows significant overlap with a lot of the vascular patient needs. One question that we ask all of our patients at the clinic is, where would you go to receive care for this medical issue if we weren't here tonight? 63% of them say that they would go to the nearest emergency department, which is Loyola's Level 1 Trauma Center, and 23% say that they would not have pursued any medical care for their problem. So this clinic both increases access to care and decreases unnecessary emergency room utilization for our hospital system. Limitations of this study included that it was a small sample size from a single institution. The lower rates of preoperative comorbidities that were seen in the unhoused cohort could be reflective of a lack of contact with medical professionals to provide these formal diagnoses rather than actual disease prevalence. There was limited long-term data due to the low rates of follow-up that were seen in the unhoused cohort after their amputation, and we also did not record the indication for the amputation procedure. In conclusion, the unhoused cohort received their amputations at a younger age. They were less likely to be on an antiplatelet or a statin medication and less likely to have received an angiogram prior to their amputation. The unhoused were more likely to experience a surgical site infection following their amputation. They had a longer non-ambulatory period and were less likely to see a vascular surgeon for follow-up care. The street medicine clinic has been an effective option for optimizing medical management preoperatively and providing postoperative follow-up care for unhoused patients who were unlikely to return to outpatient clinics for medical care. Thank you, and I'm happy to take any questions.
Hi, Leanne O'Banion from UCSF Fresno. That was a great presentation. I just had a couple questions for you. So you noted that you had a longer time to ambulation while the patients were inpatient. Is that correct?
Correct.
So does Loyola employ an ERAS-based care to patients with major amputation, or why do you think there's a difference regarding to their housed situation and why they're not getting up sooner? Is there a difference in when PT is consulted? What's the reason for that?
Yeah, so we didn't investigate that specifically, but kind of anecdotally, I feel like a lot of times these patients are in the hospital for so long after their amputation because of the discharge disposition question of where is this patient going to go? And when there's not always a clear answer or an end in sight in terms of getting the patient off the list, I think sometimes that can cause physical therapy to be consulted later if there's an assumption this is a patient who's going to be here forever, when we do try to optimize, getting up and ambulating as quickly as possible after an amputation.
Yeah. So, I mean, I just think, when you reduce care variation, there's a lot of data that shows that it eliminates those healthcare disparities. So, I know that, the SVS has published their guidelines on ERAS amputation, guidelines for patients with amputation. And so when you can consult PT right when they get their amputation, then there's no question about when they're going to get it. My only other second question, because I'm in California, so it's a little bit different with Medi-Cal, but for the Medicaid population, because that seems like it's most of your unhoused population, do you have an underserved clinic where those patients can get follow-up, and are they established follow-up in those clinics when they're discharged?
So those clinics do exist, but a lot of the time we see that even when the patients are referred to go to them, they won't make it there for various reasons, whether it be transportation issues or they just feel uncomfortable going into an outpatient clinic setting. So even though those clinics do exist, a lot of times kind of going to the places where these patients tend to be and just providing the care that way is the best option.
Great.
Thanks.
I think you were next, and then we'll go there.
I just want to say, I think the idea of your underserved clinic is fantastic, especially considering that you have a dedicated line that you're seeing increase patient population month by month, year by year. With that change since 2021, have you seen a decrease in the amputation rates in your unhoused population?
Yeah, so I think the timing's interesting because this chart review that we did was from 2007 to 2021, and then we started this clinic in 2021. So we haven't had a chance to kind of look at the effects of that, if it is decreasing amputation or even just improving outcomes post-amputation, but that's something that I think would be nice to look at in the future.
And then a subsequent follow-up to that, looking at your overall patient inclusion criteria for the data, you had 1,300 or so total patients, and only 50 or so were listed as being unhoused. What do you think is the limitation in outside of just zip code and gathering that patient population data in terms of maybe creating a future public health option for them?
Well, I think the limitation was we had to manually chart review all 1,300 of those patients to discover the housing status. There's a series of like 5 ICD-10 codes related to homelessness that can be put as like a diagnosis in patient's chart, which I think is a good idea because if we're seeing that homelessness is related to 12-year or earlier mortality, then that's something that should be noted in most patients' chart if they are homeless. But that's kind of something, those ICD-10 codes is something newer that's been instigated, and so a lot of the earlier charts that we looked at didn't contain those codes, and so in order to confirm that patients were actually unhoused, we had to look at the social worker and the physical therapist notes, and so that's just really time-consuming and hard to do on a large scale.
Understandable. Thank you very much.
Yeah.
Dr. Succo is going to let us do a couple more if we go really quickly. So,
Hey, Michael Barfoot from Chattanooga. A lot of these patients, obviously, you're looking at time of ambulation, have varied access to prosthetics care depending on where they're in the country. I don't know the Chicago area very well, but just curious if there was a difference in how many of those who were unhoused actually were able to receive a prosthetic and what the prosthetic care after that looked like. You mentioned a lot regarding follow-up with vascular surgeon, but just kind of curious about that.
Yeah, so that was a variable that I was interested in looking at. I didn't present the data here because that, again, was something that required a lot of chart review to actually determine who had a prosthetic and who didn't. But I was able to go through for at least the unhoused cohort, and none of those patients received a prosthetic. And so I didn't include that data because I didn't have anything to compare it with in the housed cohort, but I would imagine that difference would be significant, and that's something hopefully to look at for the paper.
last one real quickly.
Thank you. David Eberts from St. Louis University. Wonderful presentation and great job presenting it. I'm curious more about the whole thought of this being how many of them are getting amputations versus an actual attempt at limb salvage, because your numbers, I think, was a strikingly 0% got angiograms of the homeless population. You all have probably one of the best outpatient homeless population outreach programs that there is. Should we increase how aggressive we are with limb salvage in conjunction with that, or do you think it's still safer that if they get to a point where their wounds are so bad, really good wound care, outpatient follow-up to the streets, and amputation might still be safer for them, or can we try to actually do limb salvage for them?
Yeah, I think in an ideal world, limb salvage would be the goal, but it can be difficult about, the time that patients are presenting. I think oftentimes when we do have unhoused patients that are presenting and requiring an amputation, the frustration is, I wish that this was a patient that we could have seen years ago, back when there was a chance at doing an angiogram with an intervention or doing a lower extremity bypass to potentially avoid the amputation. I think one of the weaknesses is the fact that we didn't look at the indication for the amputation. So there is a possibility, like CLTI with tissue loss versus CLTI with rest pain versus just an uncontrolled infection versus frostbite injury. I think there's a lot of reasons for the amputation that weren't necessarily investigated with this study, and that would be something to look at in the future too.
Thank you. Thank you very much.
Thank you.